Well, thank you again, guys. I'm really honored to be here with you all today. I want to begin by officially thanking the Alliance for People of Color and Postpartum Support International for hosting this World Maternal Health Forum and for creating space for these really important conversations. Welcome to my presentation centering stories, changing systems. Today, we'll focus on how lived experience shared through family narratives can strengthen maternal mortality prevention efforts. We know that across the U.S., we continue to face serious challenges related to maternal mental health and maternal mortality. And the data clearly shows us that this is a problem. But I want to begin with a simple truth that while the data matters, our stories matter too. We truly have this opportunity, this unique opportunity to recognize that without the voices of women, birthing individuals, families, and communities, we miss the context, the lived experience, and the humanity behind what the data is telling us, what it's showing us. So again, I'm truly thankful and grateful to be in this space with you all as we center this very important topic. Okay. Patience already gave a really wonderful introduction. That was beautiful. Thank you so much. I'll just add that, over the last few years that I've been into the maternal health space, about specifically the maternal health space, 6 to 7 years, I've had the opportunity of speaking with more than 200 families across Mississippi and Louisiana who've been impacted directly by maternal mortality. And those conversations have taught me a lot. They've really instilled in me that behind every data point, there is a life, there's a family, there's a community that's now forever changed. And they've also shown me how these stories hold critical insight. They really help us to better understand not only what happened, but these stories help us to understand why it happened and what could have been done differently to help prevent these deaths from happening. And so before we begin, I did want to invite us all to join together in solidarity for a moment of silence. This is truly a time for us to honor the lives of these mothers who have been lost to maternal mortality and honor their families. These are families that are now forever changed. And so as we move forward through today's conversation, we're just not learning from this data, right? But we're learning from lives, from the stories of individuals who have been lost. And so I'd like for us to just take a few seconds to hold some space and honor these mothers whose story guides this work and help inform maternal mortality prevention. Thank you so much for sharing that moment with me. So it wouldn't be a presentation, right, without a few learning objectives. And so today, at its core, um, this conversation will be about strengthening relationships in maternal mortality prevention. It's also about centering empathy, collaboration, mutual respect as some of the foundational pieces to how we understand and respond to maternal loss. We know that if we're going to center prevention, we know that these things don't happen in isolation, right? It requires coordination across healthcare systems, review committees, communities, so that our responses are more effective and person-centered. So today we're going to focus on about 3 areas. First, we're going to kind of talk about family narratives and what they often, well, we often refer to family narratives as qualitative interviews. And through these family narratives that we have with family members after a maternal death happens, we know that we're able to fill in critical gaps in lived experience, social context, and systemic barriers that may not be fully captured in that woman or in birthing individual's medical records. We'll also talk about the importance of trauma-informed culturally responsive care. And we'll also talk about how lived experiences can become more actionable, how we can translate our stories into equity-driven recommendations that can help us to address issues like bias, racism, and preventable maternal deaths. So I'm going to be kind of talking a lot and using certain terms quite frequently. So I thought it'd be important to kind of ground us and kind of talk about what these things mean, right? So when we talk about maternal mortality, we're referring to the death of a woman or birthing individual either during pregnancy, at labor and delivery, or within that first year postpartum period. I'll also talk a little bit more about maternal mortality review committees. Almost every state has a maternal mortality review committee. They're also referred to as MMRCs. And these are basically interdisciplinary groups of professionals that meet to review these maternal deaths to get a better understanding of what happened, whether or not that death was preventable, and what recommendations can be crafted to prevent future deaths from happening. And I know I'm in a space where a lot of you already know what lived experience is, but for some folks who are new to the fold, lived experiences are basically the firsthand realities of women or birthing individuals, families, and communities who have navigated pregnancy, birth, and the postpartum period. And when we talk about family narratives, in this context, family narratives are the stories and perspectives shared by loved ones after a maternal death. And these narratives help us to understand what may not be fully captured in the medical record. And so, together, these terms really help us frame how stories and data can work together to strengthen maternal mortality prevention. So, why does maternal health matter? Well, I know that I'm already in a virtual room, a virtual space full of people who already believe that maternal health matters. And, I know I do. But if we kind of zoom out for a moment, I think all of us can really sit with the reality that there is no path forward where communities can grow and thrive without centering the health and well-being of mothers and babies. And across our country right now, and especially in communities most impacted by inequity, expecting and postpartum mothers continue to need more support, more resources, and systems that are truly designed to help them thrive. And maternal health matters because it's connected to everything, right? Maternal health is connected to our mental health, it's connected to the infant's health, it's connected to family stability, community well-being, and the strength of our healthcare systems. And I think that that concept really connects to the overall theme of this forum, right? Connecting the dots. And when we center maternal mental health and maternal health, we begin to see how those dots are connected through clinical care, mental health, social support, policy, community systems, all the things. So as we kind of continue to navigate it deeper into this conversation, I'd want us to kind of sit with that notion, right? That when mothers are supported, families are strengthened, and communities are better positioned to thrive. Okay, so why do conversations with family members matter after a maternal death happens? Again, we just talked about how if maternal health is connected to everything, then understanding maternal health requires us to connect the dots across all of those experiences. And the question becomes, how do we actually do that? How do we move beyond what may be documented in this mother or birthing individual's medical record to connect to what she actually experienced? Because what's written in a mother or birthing person's record, medical record, may not fully reflect how that woman or birthing individual experienced their care, right? And that's why stories matter. That's where stories come in. Because in this work, stories are not just stories, they are data. And we're going to talk about that in a little bit too. But our stories help us see the context that the charts may miss. They help us to surface, contributing factors that may have led to the death that aren't exactly pinpointable or identifiable in records. And they help us identify opportunities for prevention. And most importantly, our stories, they help us deepen our understanding of lived experience and where systems may have failed. So when we talk about strengthening maternal health systems, we can't just rely on that data alone, right? The traditional percentages, ratios, numbers, stories matter too. So again, I think it's important for us now to kind of talk about why conversations with family members are so important. For today's discussion, I'll use the term family narratives a lot because I think that family narratives better reflects the purpose of this work. Listening to loved ones most impacted by maternal deaths, honoring their perspective, and understanding that the story is really beyond what we see in the medical record. And when we talk about these conversations with family members, they are truly structured, trauma-informed conversations with a family member or loved one after a maternal death. This person typically has a unique, special relationship to the individual that has passed. And a part of the review process, we talked about those maternal mortality review committees, right? A part of their review process, they are examining these deaths to understand what the contributing factors were to that death. Again, they're also tasked to determine whether or not this death was preventable. They're also tasked with developing recommendations for change. How could this death, if it is preventable, what could have been done differently to prevent this death from happening? And family narratives are a huge part of that process. So, no, they don't replace the medical record, but they help provide a more complete picture. These conversations with family members and loved ones can help reveal social factors, warning signs, maternal stress, care barriers, and again, amplifying lived experiences that may not be documented anywhere in the medical record. And most importantly, I think they help bring forward the voice of family and the story of the woman or birthing individual whose life was lost. They help provide context, again, beyond what the medical record can provide. So now we want to talk a little bit more about the drivers of maternal health outcomes. What are things that are really driving these maternal health outcomes? And when we navigate into this conversation, I think it's really important for us to recognize that maternal health outcomes are shaped by multiple interconnected factors. Maternal health isn't determined by clinical care alone. It's often influenced by a broader set of drivers that affects a woman or birthing individual's life before, during, and after pregnancy. So, clinical health factors can certainly play a role, right? We know that underlying conditions can contribute, and of course, access or lack of access to quality medical care. But we also know that social determinants of health, things like housing stability, transportation, employment, and access to resources, can significantly influence outcomes. Community and cultural factors also matter. The level of support a woman has, the norms within her community, the trust that she has with the healthcare system can all shape her experiences. And when we listen to family narratives and lived experiences, we often begin to see how these different factors intersect. These stories help us to understand how these drivers show up in real people's lives and where prevention opportunities may have existed. So some recent data came out last week, and I wanted to share some of that with y'all. Like I had kind of altered my presentation to kind of whip in some of this data that just got released last week because I really wanted y'all to have access to it. Um, on the previous slide, we talked about the drivers of maternal health outcomes, and I think this slide really helps us to again connect the dots to see how those drivers show up unevenly across populations. The latest CDC data shows us that pregnancy-related deaths do not affect all communities the same. Black women continue to experience disproportionate burden of pregnancy-related deaths. And, in that same conversation, we also see really big disparities among American Indian and Alaskan Native women. So when we talk about disparities, we are not just talking about individual risk alone. We are talking about systems, history, access, bias, racism, and the conditions that shape care before, during, and after pregnancy. And again, this is why lived experience and community context are essential. The numbers show us where the disparities exist. Stories help us to understand how those disparities are experienced and where prevention efforts may focus. Maybe a few weeks ago, I gave a similar presentation, and I got a question from the audience that was asking about these figures. A young lady in the audience said, "Well, the percentage bar for the white demographic is actually the highest on this spreadsheet." Yes, and while that may be true, I want you to note that we're looking at the presence of these deaths are disproportionate to the presence of this ethnic group's presence in society. So, black African American demographic is only 13%, roughly 13% of the U.S. population, but they constitute about 29% of all pregnancy related deaths, and that means that is disproportionate to their presence in society. And again, with our Native population, they are constituting about 4% of pregnancy-related deaths. But I believe that our American Indian, Alaska Native women or Native population are only about 2% of the U.S. population. And so that's what we mean we talk about disparity. So, continuing our conversation about maternal mental health conditions, when we look more closely at these disparities, the next question becomes: what is driving these deaths? What is driving these disparities? What are the underlying causes, right? Because understanding who is most impacted is only a part of the picture. We have to understand why. And when we look at national data, one finding that stands out, right? We can see from this chart that mental health conditions from a national perspective are the leading underlying cause of pregnancy-related deaths. One would think that, it would be medical related, right? When we think about pregnancy-related deaths, a lot of times our minds automatically gravitate to a medical condition. But no, that's not the case. Mental health conditions are the leading underlying cause from a national perspective for your state. If you're in the US, I know we're on a global platform here, but in the US, depending on your state, it can vary state to state. But collectively, in the US, mental health conditions are a leading underlying cause of pregnancy-related deaths. And so this includes suicides, overdose, and other mental health-related causes. And this is really important for us to center, especially in this space, you all, because mental health conditions are often less visible, right? Less discussed, and sometimes missed entirely in clinical settings. But as we've been talking, this is where lived experience becomes essential. This is where sharing our stories becomes essential. Stories help us understand what was happening beneath the stories. I'm sorry, beneath the surface. Stories help us capture the stress, the trauma, the isolation, the barriers to care. Stories help us to um, see things that may not always be fully captured in the medical record, right? So when we look at this data, I want us to think not just about the causes, but opportunities for earlier identification, support, and prevention. So I wanted us to take a deeper look at this data that just got released not too long ago. This data that falls within the context of mental health conditions. I think we kind of named what this means in the previous slide, but I actually want us to go a little deeper. We're not just talking about depression and anxiety. Pregnancy-related deaths tied to mental health conditions can include, again, suicide, overdose, poisoning related to substance use, or other deaths that the Maternal Mortality Review Committee identified as connected to a mental health or substance use disorder. For example, a mental health condition may affect a mother's ability to recognize her symptoms, attend follow-up appointments, take her medication consistently, or to ask for help or support when something feels wrong. On the flip side, when we talk about substance use disorder, this condition may also increase a mother or birthing individual's risk by complicating other health conditions, delaying care, or just, increasing vulnerability during the postpartum period. And so when these maternal mortality review committees identify mental health or substance use as a contributing factor, they're often looking at how these conditions intersect with clinical care, social support, safety, access to treatment. And again, this brings us back to why lived experience matters. Without understanding what a mother was experiencing during that time, we really miss or have the possibility to miss critical opportunities for understanding and understanding what could have been done differently for prevention. So now we're talking about recognizing those overlooked pathways to um, we're looking at the over risk pathways to recognizing maternal death. Often, when people hear maternal mental health related deaths, again, their minds go to suicide, but suicide is only a part of the picture. As we noted earlier, mental health related deaths can also, again, include overdose, poisoning, and we know that these deaths may be classified differently or not recognized or connected to maternal mental health conditions until we talk to the family members. And this slide really helps us to recognize those overlooked pathways, those pathways to pregnancy-related deaths that often get overlooked. Again, like suicide and overdose, because a lot of times we immediately gravitate to medical related conditions. And so this helps us to better understand that when we look at the data, that a significant portion of these mental health related deaths are not only tied to overdose, but also, suicide. So this explains or should expand how we think about risk, screening, prevention. It should also remind us that mental health, substance use, and physical health, all of these things are deeply connected, and our systems have to adapt to be able to respond in ways that reflect that complexity. So we're navigating now, talking a little bit more about um, Black women. When we look more closely, we see that mental health related pregnancy deaths are increasing among non-Hispanic Black women. And that increase is very significant. What we're seeing here reflects more than individual risk. It really reflects gaps in connection, gaps in protection, and missed opportunities for prevention within systems of care. So, this is not just about identifying mental health as a leading cause. It's also about recognizing how these outcomes are experienced differently and more heavily by Black women. And again, this brings us back to why lived experience matters. And a little later on in our conversation, we're going to tie into how lived experience, particularly for Black women, can help improve outcomes. But this is important to truly understand these trends. We have to understand the context in which they are happening. And now we're going to kind of navigate into a little 3-minute clip about a Black mother sharing her experience with coming to terms with postpartum depression.
I never thought that I'd end up with an emergency C-section or with pneumonia or in the ICU. So just starting out in my role of motherhood was slightly grim for me.
36-year-old Nikki Gill Adams and her husband welcomed their son Alexander into the world on April 1st, 2019.
I spent a week in the hospital, and before I left, the therapist came, and all I could do was cry. At that time, I wasn't well. My emotions at that time, this isn't what I thought it was going to be.
Postpartum depression is a condition in which the new parent may experience persistent feelings of sadness, emptiness, low energy, anxiety, irritability, and poor sleep or appetite. PPD affects over 11% of mothers in the U.S. A study conducted at Mount Sinai School of Medicine in New York found Black women were twice as likely to experience postpartum depressive symptoms as white women. The risk for Latin women was also almost twice as high.
Using that term postpartum is so tough, right? Labeling that you have postpartum depression, being a Black woman, the stigmas related to that. Girl, you just had a baby. You're supposed to be happy. This is what you prayed for.
The CDC points to specific socioeconomic factors to the likelihood of developing PPD. Things like implicit bias linked to patient-provider communication, marital status, and the lack of access to employment with insurance coverage.
You're restricted to a certain pool of behavioral specialists or mental health specialists or therapists that may not look like us, that may not identify with our struggles.
Research suggests as many as 50% of all women with PPD do not report it. Even after diagnosis, Black women were 57% less likely to start treatment, and Latinas 41% less likely than white women.
The moment I started talking and figuring out that I was not alone, that was my place to turn around and begin healing.
Traditionally, not all insurance companies offer behavioral health care coverage. While some companies have increased availability in recent years, there are still wide gaps in coverage and issues with access to providers.
I never thought.
I really love that that was a news segment clip, and I really like it. It just shows how powerful sharing our stories is. And just imagine how many mothers that watched or tuned into that broadcast that maybe didn't know what they were, the feelings or emotions that they were navigating with, could identify with that mom and feel more empowered and safe in reaching out for support. Again, as we think about maternal mental health deaths, this is where family stories become important. The medical record may document diagnoses, medications, appointments, emergency visits, but it may not tell the full story of what was happening in someone's life between those encounters. And family narratives can help fill in those gaps. They may help reveal stress at home, trauma, relationship concerns, stigmas, barriers to care, the warning signs that weren't clearly reflected in the medical record. And this context matters because most pregnancy-related deaths are considered preventable. As you can see, 85%. This is recent data that has just come out, capturing data from 2022. 85% of pregnancy-related deaths are preventable. So, our reviews, when we review these steps, it just can't stop at identifying what happened. We have to understand what support, what intervention, or what system response may have changed the outcome. And so when these committees meet to determine whether or not a death was preventable, basically they are saying that there was some type of support, some type of service, some type of medical intervention that could have taken place that may have saved this, that may have or could have saved this person's life. And so when we center stories alongside the medical record, review committees, the committees that are tasked to review these deaths, are better positioned to identify missed opportunities and develop recommendations that are meaningful, responsive, and grounded in real life. So I've been telling y'all we're going to connect to why storytelling is so important and how it improves outcomes. And what we're seeing is that our stories matter deeply. CDC data show that about 1 in 5 women report mistreatment during maternity care. But that number rises to about 40% for Black, Hispanic, and multiracial women who report discrimination during care. So for many women of color, talking about Black women, but also talking about women of color, for many women of color, these experiences are not isolated experiences. They are patterned, they are repeated, they are systemic. And when we connect this to what we know about birth trauma, the picture becomes even deeper because we know research shows that about 1 in 3 birthing people report feeling traumatized by their childbirth experience. And mistreatment during care is one of the leading contributors of that trauma. We also know that women of color are at increased risk for both interpersonal and obstetric complications, which further risk or increase their risk for experiencing a birth trauma. And that means experiences like feeling dismissed, feeling rushed, not listened to, or not included in their care decision making are not just frustrating moments. These are deeply or can be deeply traumatic experiences that have long lasting emotional and psychological impacts. So when we talk about higher rates of maternal mental health conditions, lower access to treatment, and increased risk for trauma among Black women, these are not disconnected issues. They are connected through lived experience, systems of care, and through the way individuals are treated within those systems. And that's again why we cannot rely on medical records alone, right? It's not like medical records are going to openly document discrimination, bias, or mistreatment. A lot of these issues are unveiled or come to surface through sharing our stories, through storytelling. And so when we say that the data shows us patterns, but stories help us understand the people behind those patterns, this is what we mean. This is what we're talking about. Stories give meaning to the numbers that we see in the data. They help us look beyond the percentages, beyond the ratios to better understand what was happening in a mother or birthing person's life, in this context, leading to her death. And so one of the things that I wanted us to do is an interactive little poll. This is pretty cool. I'm gonna have to launch the poll. 1 second. So basically you whip out your phone and you can scan the Slido poll. I gotta launch it first. There it is. Okay. And we're gonna this is anonymous, guys, so you don't have to feel like, oh, I don't want to say what I really want to say. It's anonymous. All of us will be able to see each other's responses, and we can kind of talk and reflect. But from this poll speaking to discrimination, from your perspective, how do bias or discrimination most often show up in the care for mothers that mothers receive from your lens? Because all of us are in this space working with moms, caring for moms, but we're all in so many different um, settings, right? Some of us are in child welfare, some of us are in clinical settings like hospitals or OBGYN clinics, some of us are in public health. And so I think it'd be really neat if we all could just briefly share some of some of what we see, what is our perspective and what we're seeing, how discrimination and bias shows up. And so, yes, I'm starting to see some responses trickle in, and we all should be able to see this.
And
And
Lejeune, we did have a question if the link could be dropped in the chat for this for our folks that are on their phones.
yeah, let me see. I should be able to drop the link. Let's see. So I got a link. I don't see a link. Oh no. I should have pre-planned for this part. I did not I did not get the link for this. I apologize. Let me see. I can go back. Let's see.
And I'm also seeing if I can do it really quickly.
Thank you. I'm sorry. I
If I
should have.
can send it. No, you're good. If I can send it to myself.
But I love these answers. Language use, socioeconomic, language, country, status, origin, dismissing, barriers, length of appointment. I recently had a colleague to express to me how disappointed she was that her wait time to see her provider was longer than the actual time that she was in the room with her provider. And she said that was deeply upsetting for her. And this is she was a mom, but now she's in her perimenopausal phase of life. And she was just expressing how disappointed that was that she had waited 45 minutes to see her OBGYN. And then when she got in there feeling rushed and feeling like, it was time for her to go, and she said that she felt comfortable enough to express that disappointment with her provider. That hey, I've been waiting for you for 45 minutes and now you're trying to get me out of here. And her provider ended up spending more time with her. But imagine how many women may have not felt empowered or safe to speak up or say something. I imagine that there are a lot. But these are all really, yeah, I see time limits with care, rushed appointments, insurance. All of these things are really great, guys. Privilege, I love that. Absolutely. Absolutely. Thank y'all so much for sharing these. So, I really appreciate those reflections that you all shared in the poll. And, as we continue this conversation, I think it's important that we look at what national data tells us about discrimination in maternity care. These findings, and these are findings from the CDC's Vital Signs on Maternity Care Experiences. These findings help us to understand that mistreatment is not isolated. It's a broader pattern, guys. According to the CDC's Vital Signs on Maternity Care Experiences, nearly 29% of mothers or birthing individuals reported experiencing discrimination during maternity care. And those rates were even higher among Black mothers, Hispanic mothers, and multiracial mothers. Women who reported discrimination related to not only race, I think a lot of times when we think about discrimination, our minds just gravitate towards race, but these mothers reported discrimination based on their ethnicity, age, weight, income, insurance status, provider bias. I think I shared with you guys earlier that I've spoken to nearly 200 families or a little over 200 families that have been impacted by maternal deaths. And a lot of those families felt as though if their loved one had have had commercial insurance, that they probably would have received better care. And that's a form of discrimination, right? Right? Feeling like if we had commercial insurance, we could have received better care. Or because we have had Medicaid insurance, we received a lesser quality care. So this data here helps us to see patterns. But, the next question is, what does the pattern actually look like in real care experiences? And this is it. This is the answer through our stories. As we navigate to talking more about lived experience, I think also, this slide continues to really solidify our conversation behind lived experience. And this beautiful figure in the center reminds us that, behind every percentage is a real person navigating pregnancy and care and vulnerability in real time. And these numbers right here just really solidify. These are also numbers from the vital signs maternity care experiences, just solidifying some of those things that we talked about earlier. In that same report, many of those mothers discussed, navigating through care while feeling judged or dismissed or feeling inferior. And so, yes, this slide really helps drive home how important capturing lived experiences is and understanding how we can better capture what mistreatment looks like. Okay, so I got two studies that I wanted to share with y'all. The first is a study from Dr. Lucinda Canty. She's amazing, y'all. She is actually on LinkedIn. If you want to follow her, she's really active on her LinkedIn. But she conducted a study to capture the importance and the impact of lived experience. And Dr. Canty is a nurse midwife. And through her study, she captures how Black women described their care experiences after experiencing a severe maternal morbidity. So, maternal morbidity is basically a near-death experience. So, she captured the lived experiences of Black women who nearly died from their childbirth experience. And through her study, capturing these stories of Black women, she was able to capture patterns of, disrespect and dismissal in clinical settings. In her study, the women reported feeling unheard, devalued, not taken seriously. There were reports in the study of pain being minimized, their concerns being brushed aside. And often these women reported, fear and mistrust and just even, of course, these women survived, but the expression of long-lasting sense of just not being safe within healthcare systems. In her study, she was also able to capture how the trauma they experienced extended far beyond the physical event itself. For many of these women in the study, surviving this life-threatening maternal complication didn't mean that the event was over. They continued to describe deep emotional and psychological effects, including anxiety, hypervigilance, and other symptoms of trauma. We'll continue. There were some couple other things in the study. She also was able to capture that how these women's experiences were often shaped by structural racism and power imbalances within the healthcare system. Someone had wrote in the interactive poll that we had privilege. Well, yes, a lot of times providers, our OBGYNs, our nurses, our nurse practitioners are in a position of power, and that is a position of privilege, right? And so this power imbalance really can create unsafe spaces for women, particularly for women who have historically been mistreated by the healthcare care system. And in this study that Dr. Candy put together, she was able to describe how race, gender, and socioeconomic status often influence the quality of care that these women received. So, The second and last study that I wanted to share with you that really helps to validate how powerful and important these family narratives that we receive from family members after a maternal death occurs is the study of Cathari and his colleagues. And in this study, they were able to showcase how the immeasurable impact of these interviews, like, and what they are able to contribute to the maternal mortality review process. So when family interviews are included in the case review, right? When we have these interviews that we've been able to conduct, we have all the medical records, but then we also pair it with an interview from the family members. They were able to identify more contributing factors, those contributing factors that may have influenced the outcome that led to the maternal death. In fact, the study found a 160% increase in the stressors identified, the stressors that this woman, this mother, or birthing individual experienced. And so, this committee, with all of this rich contextual information, we're able to generate 40% increase in recommendations. So they were better equipped to provide recommendations on how this death could have been prevented when an interview with the family was provided, right? In addition, in this study, they were able to reveal that, you know, with the interview, they were able to gain a better understanding of what the charts frequently miss, those social determinants of health, gaps in communication, or failures in informed consent. I did want us to take a couple of minutes to read Jessica's story because we have this is our second and last mini group activity that I put together for us. But yes, I wanted us to read Jessica's story. So this is the type of information, if you were on a maternal mortality review committee, you would receive information like this about a case of a woman. And basically, if you don't have access to the family interviews, all you would have is that medical information provided in the chart. So Jessica was a 29-year-old Black first-time mother with limited prenatal care, attending only 4 prenatal visits. At 36 weeks, she developed severe preeclampsia and delivered by cesarean birth. During her hospitalization, Jessica continued to have elevated blood pressure, severe headaches, and swelling. Her discharge was delayed once due to concerns about her blood pressure, but she was later discharged on postpartum day 4 with a prescription and instructions to follow up in 1 week. After discharge, Jessica missed her postpartum appointment. At 14 days postpartum, she called the clinic reporting that she was feeling unwell, but no same-day evaluation was arranged. She was scheduled for a follow-up appointment, but the appointment was set for 2 days after her death. On postpartum day 21, Jessica collapsed at home and was transported to the emergency department, where she died. Her cause of death was attributed to complications related to postpartum cardiomyopathy. So again, these review committees typically, and I'm going back to our second poll, I'm about to launch that. This is the kind of information that you are given, the basics. But I would like for us to all chime in. If you were evaluating Jessica's case to determine whether her death was preventable, what additional information would you want to learn from her family? What questions would you ask to better understand Jessica's lived experience? Take a few moments to just think about that. What are things that you would have wanted to know? And these will be the things that we will ask the family to better understand. I see folks trickling in. I see some things, little, this means things are family history. Sure, absolutely. What was her family life like? What was her support system like, right? I would want to know that. Support systems are huge. A lack of a support system can be very detrimental. That was excellent. Follow up from missed appointment. Yes. Why did she miss her 1 week follow-up appointment? That's a big deal, right? Because we know she only received 4 prenatal visits, which is typically on the lower side of things, right? So yeah, that's great. What was Jessica's released with that this kind of moving fast. It says, what diagnosis was Jessica released with postpartum? Very good. Did anyone follow up with her? Right. Did anyone call to check on her? Was a virtual option made available to her if she knew that she wasn't going to have the transportation to come? Who was taking care of her at home? Excellent. Yes. Previous medical history, her resources and support systems. These are great questions, guys. Absolutely. Yes, we would want to know these things because all of these things could have contributed to her outcome. I would have wanted to know when she called, that she was feeling unwell, like why she couldn't be seen that day, you know? These are great, guys. Great. I love it. But yes, when we look through the medical record, we just get those facts. We see the postpartum visits that she only had that she missed. We saw limited prenatal care. We saw unanswered call for help, and we see what the cause of death was. But that's only a part of the story. When we listen to family voice, we create a space for lived experience, right? We could have learned that she lived in a rural area and didn't have her own transportation, and that's why she only had four prenatal visits, and that's why she missed her 6 week follow-up, right? We may have learned that, she needed help, but she felt afraid to ask for help. Another big deal is like through these family interviews, we're able to get a better glimpse into how she felt about her provider. Did she have a good relationship with her provider? Did she feel like she could communicate with them and speak freely with them? Those things are important and they contribute to our health outcomes. I did want us to pivot a little bit and talk about trauma-informed care. I wanted us to kind of, because now we've done a really great job of painting a picture of the problem. I think now it's great to kind of talk about, okay, how do we tackle this? What are solutions? And so trauma-informed care is a pretty big deal. Um, when we listen to families and we review these cases and we absorb the lived experiences and we can see and identify where systems have failed, you know, what do we do differently? That's the next question. How do we navigate differently? What can we do differently? And an important strategy that continues to emerge across maternal health research and maternal mortality review is the adoption of trauma-informed care. Trauma-informed care helps us to recognize that many individuals are entering healthcare settings, uh, especially those navigating, complicated pregnancies, loss, or severe morbidity, may have already had experiences related to trauma, right? So rather than only focusing on the clinical treatment, embracing trauma-informed care means that we're embracing strategies and an approach that helps to reduce re-traumatization. And SAMHSA has a really wonderful model that's really popular that a lot of folks embrace, and it embraces 6 core values that are centered around establishing safety, trust, choice, collaboration, and empowerment in every interaction that we have with our families, with our mothers, with our birthing individuals, right? It is considered a evidence-based prevention strategy. So we are being very intentional about creating environments that prioritize these core fundamentals: empathy, transparency, respect. And when we do that, we reduce the likelihood of harm and we improve the engagement with care to better support these women, these mothers, these birthing individuals, in turn helping to support their ability to support their families. and again, reducing the prevalence of maternal death. Transitioning a little bit to talk about a few evidence-based strategies that can improve maternal health outcomes. Again, we just got through talking about trauma-informed care, which is huge, helping us to create these safe spaces, these respectful environments. Second is implicit bias training, right? And implicit bias training really helps providers in recognizing their own biases. All of us have our own biases, but it's important that we recognize those biases because that will help us and equip us to build more equitable, trusting relationships with our clients or our patients. And a third is clinical and therapy interventions, which, therapy is great. Peer support, I should have put that in there too. Peer support is great. And together, these integrated approaches can really help strengthen care for mothers and families. I did want to highlight just some simple evidence-based strategies from a maternal mental health angle. Again, screening is always going to be a big deal. We should be screening. We should be encouraging screening and screening early and often. Also, mind and body wellness activities are very, very important, or interventions are very, very important as well, because these things help to reduce stress and help support emotional well-being, and also help to support healthy coping during pregnancy and the postpartum period. And then together, these approaches can really help us to build a more comprehensive system of care. Again, I know I put a lot of heaviness in this conversation, but I do want y'all to know that there are a lot of systems working together to prevent maternal deaths. This work doesn't happen in isolation alone. There are, I think I mentioned to you, there are almost in every state a maternal mortality review committee that's working to identify these deaths and to determine whether or not they're preventable, and to create these recommendations that they all put in these nice reports that they publish annually, that can kind of inform us all on what we can be doing to prevent these deaths from happening. There are also organizations like perinatal quality collaboratives in almost every state as well. Maternal health task forces are big. Almost every state has a maternal health task force. And of course, the wonderful community-based organizations that are boots to ground in so many of our local regions that are working directly with families, with mothers, to be the action arm in what the recommendations are to prevent these deaths from happening are a really big deal as well. The next video is a little 2-minute video. It's from the CDC's Hear Her campaign. And I know we're about to close. This is like my last video, and then I'm going to go to questions. But the CDC's Hear Her campaign is a wonderful campaign. They have tons of videos, guys. I really encourage you to go to their YouTube channel. But they launched a campaign which was pushed by the CDC's Division of Reproductive Health. And again, it's a public health initiative focused on raising awareness to inform moms about the urgent maternal warning signs that are red flags for, like, if you're experiencing something and you need to go to the doctor. And I love this campaign because it's kind of embracing a storytelling approach to how we can center prevention. And so we'll watch this and then we'll go into questions.
That's my job. That's what I do. I'm a mom. I have 4 kids. It's a handful. It really is. I knew with this pregnancy something didn't feel right. I felt different. I felt a different type of pain, headaches. I felt like something was wrong. So I went to my doctor to find out what was going on. And they said, okay, it's just pregnancy related, but that did not stop me. I told my family members, and they were like, everyone goes through it. I told my spouse what was going on. He was like, "You're exaggerating. Everyone goes through it. You told me this with all your pregnancies." And I was like, "No, something doesn't feel right, regardless of how many times I was turned down and I was turned away." I just kept going back and forth to the doctor until I figured out what exactly was going on with my pregnancy to make sure everything was okay. I had constant chest pains. It felt like someone was stabbing at my chest. It felt like I couldn't breathe for about a good 3 to 4 minutes, and it was painful. I felt a burning feeling. I felt like I couldn't breathe sometimes, and a couple of times I actually passed out from it. Um, I still didn't know what was going on. I went to get it checked out, and once again, they stated that everything was normal with me, but I knew something wasn't right. I felt relieved when I found a doctor that can actually hear me out. I ended up in the hospital about, I would say, more than 10 times. I was in labor for 24 plus hours. He came out 7 pounds and 6 ounces. I'm happy that he's okay. Being a mom to me is very important. It's nothing I would take lightly because you never know what might happen. Speak up and continue to speak up and make sure they hear you out. Hear her. That's my job. That's what
I just love it's a compilation. It's so many different women's stories from so many diverse backgrounds. It's beautiful. If y'all have time, I usually tear up really bad watching those beautiful testimonials. But I think there's power again in that storytelling component where we're sharing our stories and we're able to connect and hearing that story. Even if you're not that mother, you could share that video with a mother who may be expecting or in pregnancy, navigating some challenging times, and it really serves like as a platform to just empower us and to center us and to uplift our stories. So I've really enjoyed you all today. I'm opening the floor to questions and do want to shameless plug encourage you to follow me on Facebook. If you would. I'm also on LinkedIn. I'm pretty active on both platforms. So yes, I would love for y'all to ask questions or reflect, even reflecting your thoughts on any of the material.
Yeah, you do have a couple of questions.
Great. I love questions.
Yeah, you have a couple of questions. So, well, one, thank you so much for sharing that. And especially with watching that last video, I see why you tear up because I always find myself having to catch my breath when I watch those stories because I I see myself as well in those stories of you know, I could have had a similar outcome. You could have had a similar outcome because we are Black women in America as well. And so coming and facing that and seeing it head on and hearing someone's words versus just a number really is powerful. And so that's why I just so appreciate the work that you do with going and talking to families and learning a little bit more and holding them after they have experienced probably the worst tragedy of their life, losing a family member's life when it should be the happiest moment that they've ever had. So, it is very such important work because these women should still be alive. They should definitely be here. But Lejeune, we did have some questions for you. One was, given that approximately 40% of Black women have reported experiencing discrimination and recognizing that institutionalized racism is difficult to address, are there any laws or public policies in place to address that issue?
Absolutely. That's a wonderful question. Thank you so much
I
for
thought so
asking
too.
that. So yes, actually, these maternal mortality review committees, in 2019, they introduced a question that they are now tasked to address is, did discrimination and bias contribute to this death? And again, I remember talking about each jurisdiction will have different numbers, right? So in Mississippi, and you can look this up depending on your state. I would encourage you to look up whatever. If you're in Indiana, look up the Indiana Maternal Mortality Review Committee or the New Mexico Mortality Review Committee. Each year they have to publish an annual report. But for example, in Mississippi, that's where I am. Our Maternal Mortality Review Committee indicated in its most recent report that 27% of pregnancy related deaths could be attributed to discrimination or bias contributing to that outcome. So yes, there are, and you're right, to your point, it can be very difficult to determine whether or not discrimination or bias occurred because it's not like they're going to be, documenting this in the medical record. But we are able, through these stories, talking to family members, asking them, did your loved one ever express to you feeling that they were discriminated against or mistreated in their care experiences? And then remember, these are folks who are deeply connected to this person. And so the likelihood that they would have knowledge or access of that to that information is very, very great. So these stories also help us to capture these elements of discrimination and bias. But that's a
Mm.
wonderful question. Thank you so much.
Yeah, yeah. Also, do you think that in recent years, people that have been around mothers have also sought new ways to effectively support them?
Ask the question again.
Do you think that in recent years, those around mothers have sought new ways to effectively support them?
I think we are becoming more sensitive to that, right? Because we're starting to create more spaces like this where we're sharing our experiences. Because back in the day, that wasn't the thing. You didn't talk about those not so warm and fuzzy moments of motherhood, right? But now we're navigating into a space where we're being more raw, we're being more real. So I do think that now we're being more intentional about speaking to the realities of motherhood. Motherhood is a spectrum, right? Um, yes, there are joys and excitement and happy tears, but there are also sad tears, and there are also fear
Mhm.
and uncertainty and all of those things. I think we've done a great job recently in just encouraging folks to listen without judgment when it comes to our moms. Because, a lot of times back in the day, mama would say, well, I went through the same thing. You'll be okay. So we don't want to be dismissive of these experiences because maybe she really feels like I won't be okay, right? And I
Yeah.
understand your experience was your experience, but what I'm feeling is quite different or seems quite different. And so we don't want to feed into mama feeling those feelings of inadequacy or imposter syndrome or I'm not good enough or even that guilt and shame too that can accompany oh, you didn't go through this and so now I'm feeling inadequacies within myself because I am feeling this way. But I think we
Yeah.
are navigating into a space, y'all, where we are creating safer spaces for moms to exist and to be raw and to be real.
And I feel like some of what you're sharing also goes into one of the other questions. They were just kind of asking about like your perspective, just based on like when people are pregnant and when we're postpartum, there's a lot of demands that are on us during that time, like life demands. And we also have a lot of expectations of ourselves during that time. And so this was kind of around it's almost like we're not allowed or given permission to show that we're struggling, that we're dealing with mental health issues or concerns. And so this person was just wondering about your view and your perspective on that. And I feel like you were kind of going into that of, hey, I feel like I have to remain silent because all of these expectations that are put on me
Yep.
as it relates to my mental health and me having to be the strong person
Yep.
and do all of the things.
Yep. And that's a great point, and to add another layer, let's add the cultural considerations layer onto it too, right? Because that even magnifies it even bigger, right?
Come
Um,
on now.
oh yeah.
Yeah.
Yeah, like we are conditioned to almost like wear all of these hats and to be strong and to be resilient. And those are even seen as like positive attributes, right? And so when we're not internally feeling strong, resilient, and on top of things, again, going back to guilt, shame, imposter syndrome, it can be very dangerous. It can be very
Hmm.
dangerous. And that's why creating these spaces are so important because it helps to validate that, okay, motherhood doesn't look this one way. It can look like a lot of different ways, and it's okay if I'm not feeling strong, resilient, in this moment. And so, too, going back to the cultural considerations for certain communities, it can even be more difficult to kind of navigate through because, you know, going to see a therapist, medication sometimes can be very taboo in certain communities. But again, I do think that we're getting to a space where we're normalizing therapy is good, talking to someone is good. And if you
Hmm.
peer support is amazing, and if you need medication, it's okay for that too. I Somebody had a beautiful analogy that, we wouldn't tell a person who has high blood pressure not to take their high blood pressure medications, right?
Yep.
Wouldn't dare tell them not to do that. And the same should be true for our moms too, right? Like we shouldn't dare even insinuate that that's not okay. Like it's okay if we need support through medication or therapy or otherwise to get through a challenging and difficult time. But again, we're not where we need to be yet, but we're getting there. We're getting there.
We're getting there also through conversations like this,
Yes.
through workshops like that you had, and talking about it more. So, and I think it is really just having those open and honest conversations about it, with our communities, with our families, and letting people know that that is still strength. You
Yes.
know, I'd rather you feel guilty about asking for help versus drowning in the water because you didn't have the support. So let's pick which one we want to feel guilty about. Let's
Absolutely.
pick. Let's pick.
Huge. I want to sit with that because we saw mental health conditions is the leading contributor of pregnancy related deaths.
Yeah.
That's huge. A lot of
Yeah.
women are suffering right now. And I'm
Hmm.
pretty sure a lot of those women, many of those women, probably didn't feel empowered to speak up or even know that there are resources to help support them. And so, to
Yeah.
your point about these creating pockets and spaces where, and again, trickle effect, right? So, we're having this conversation here in this moment, but then we're all going to go to our own spheres of influence and then it's going to trickle out. And so, this meeting will touch the lives of so many other individuals, and we just have to
Hmm.
keep replicating this in different pockets in different spaces.